have clear and consistent evidence showing that exercise, in fact, can reduce symptoms of people with depression, regardless their depressive symptomatology at the beginning of the trial, regardless their gender, their age.
Exercise is a best buy, but a tough sell. So, great benefits, and everyone knows of it. And there's been this proliferation, explosion of knowledge on, the great outcomes that exercise has, both physically and mentally. Yet, rates of physical activity on a national and global scale are still very poor in terms of people meeting the national guidelines, right? So, this is the big problem that is yet to be unlocked, is how to bridge that no-do gap.
If you just tell someone that he or she should stop smoking and just prescribe, maybe you should stop smoking every day and start smoking 5 days per week, and then 4, and then 3, and then 1 per week, and then you can just quit. And that doesn't work. This is not what happens in real life. So why should we believe that that approach would work for making someone exercise? Aerobic and strength exercise, or the combination of them, all of them are effective to reduce depressive symptoms.
Before we dive into today's episode of the Mental Wellbeing College, an important disclaimer. We do dive into the weeds of mental health, which means that at times we discuss sensitive topics like suicide, self-harm, and substance abuse. If hearing such discussion does bring up distress for you, please do seek the psychological and professional treatment that you need. The content covered in this episode is not intended as a substitute for professional mental health treatment.
Hello everybody, and welcome back to the show. It's fantastic to have you guys back. Today is a special milestone episode. It is episode number 50, which means, well, we have a saying here in Australia, and British viewers would be familiar with this: time to quote unquote raise the bat, which is a bit of a cricketing analogy for those who care. In any case, nice little milestone, episode number 50. And I want to take the next minute or so just to give listeners a bit of an update about the direction of the podcast moving forward, give you guys informed choice as to whether you want to continue following the show and future episodes, given a bit of change in direction. You may have noticed that a lot of episodes lately have been on the topic of exercise psychology, something I'm really passionate about and believe in the real benefits and utility of in terms of a mental health intervention. And I say believe in, but believe based off the huge evidence base there is for this. And the reason is, or at least it's connected to, is I have started my PhD in exercise psychology, nutritional psychiatry, and other lifestyle-based interventions at the University of Sunshine Coast, which is exciting, certainly to hopefully contribute meaningful, impactful research to this field moving forward. But it also means that with the podcast, we're certainly going to be looking at more episodes and discussions with experts in exercise psychology, in nutritional psychiatry, and on health behavior change and how to get people to actually make sustainable changes to a range of health behaviors. So a little bit of a pivot and doubling down in that direction. If that matches well with your own interests, please do continue to follow and stay tuned for weekly episodes, because there'll be more on those particular topics. For example, we have our first of many nutritional psychiatry deep dives coming up later in this month. So just a bit of an update, and make sure you hit subscribe, follow if that matches with your own interests and you want to hear more episodes in that area. Now to today's episode with Professor Felipe Schuch. This has been an awesome episode. I have been looking forward to speaking to Felipe for many months since I first came across his research, because he is one of the, if not the most highly cited researchers in the field of exercise for depression. Felipe is also an adjunct professor at the Federal University at Santa Maria. He's a member of the Depression Lifestyle Medicine Task Force of the World Federation of Societies of Biological Psychiatry, and the International Society for Bipolar Disorders Task Force on Nutrition and Exercise. When it comes to exercise in depression, I don't really think there's a better person to speak to than Felipe. He's, like I said, one of the most impactful and highly cited researchers, and it's been a really cool experience just to dive in and learn from his vast knowledge. And in today's episode, what we do discuss is the antidepressant effect of exercise, why what's the best exercise for depression isn't really the best question to be asking, research and evidence on the adherence problem of exercise, possible mechanisms explaining why exercise works for depression, and we look at this from a neurobiological and from a psychological point of view, and much, much more. So if today's episode does bring you value to your life, we'd be super grateful if you were to hit subscribe, follow, share this podcast with someone you love, or to leave us a review on Spotify or Apple Podcasts. This is how we continue to grow the show, and it certainly is our mission to provide evidence-based discussion and tips and strategies for people to action and implement in their own life in the way of well-being and lifestyle behaviors for mental health. Each week is a deep dive with an expert where we go very deep into the evidence so that you have a trustworthy source of information in a world that's often crowded with not so accurate or questionable information on mental well-being and health behavior changes. Thanks so much for tuning in. I really hope that this does add value to your life. And now to today's discussion with Professor Felipe Schuch on exercise in depression. So, Professor Felipe Schuch, welcome to the Mental Wellbeing College.
Thank you very much for having me, Indy. It's such a pleasure to talk to you and all the uni students.
Yeah, it's fantastic to have you on. You're obviously one of the most prominent and highly cited researchers in the exercise for depression space. And it's been really fantastic just to read through your work. So the opportunity to dive into and bring that work to life and the next hour or so is really cool. And I'm very excited to dive into this with you. And given your prolific research, Felipe, I'm curious, how did you get into researching into this space, into exercise for depression? What's the background there?
Okay, that's a funny story because when I was doing my undergrad studies, I had a depressive episode. I passed through that thing, and at that moment, it coincided with the moment that I stopped to do my exercise. So obviously, that was not exactly the cause of my depression, but it was somehow related temporally, and this is why I decided to study this topic. And when I was doing my treatment, my psychiatrist said that maybe you should start to doing your exercise. That's something that you enjoyed in doing, and maybe it was good for you. And that was the point that I really thought that could help not only my body, but also my mind. And then I searched for my supervisor, and I met, that's a professor at the Federal University of Rio Grande do Sul in Porto Alegre. And yeah, that's how it started. And,
Yeah, wow, okay. Sounds like a very interesting journey, and it seems to be the case with many people that there's a personal connection. I hear about research being me-search, and it sounds like that's the case for yourself as well, that there's a real personal connection to what you're doing now.
Yes, indeed. So this is how it started.
So, you mentioned a word there, clinical trials, and obviously you've done a lot of trials in this space, Felipe, and I'm wondering if you could give us a bit of a summary of the evidence for exercise as a treatment in depression.
Yeah, sure. So, yes, very briefly, the first trial that I did was a randomized clinical trial trying to evaluate the effects of exercise in people with moderate to severe depression with inpatients in a psychiatric ward. And that started in 2008 and ended in 2015. And in that trial, we just wanted to know whether adding up exercise could help to alleviate depressive symptoms and improve quality of life of these inpatients. So this is my first trial and how I started doing clinical trials. But now we have a lot and lots of evidence showing that exercise can help to alleviate depressive symptoms. And obviously, a clinical trial is somehow limited to a specific set of participants. But now we have enough literature from different settings, different authors in different countries, uh, using different exercise approaches. That means different intensities, different volumes, and different frequency or weekly frequency. And when we have all the literature all together and we evaluate all the studies that we have using meta-analytic techniques or running meta-analysis, we have clear and consistent evidence showing that exercise, in fact, can reduce symptoms of people with depression, regardless their depressive symptomatology at the beginning of the trial, regardless their gender, their age, and any other factors that can potentially that could potentially modify the effect. But no, we have consistent evidence showing that exercise indeed works for depression.
Mm. And when you say consistent evidence, it seems like there's dozens of these meta-analyses showing positive results, and some of which your even meta-analyses show very large effect sizes as well. So quite a big effect on a reduction in depressive symptoms.
Yes, now we have lots and lots of evidence. I guess we have over 20 meta-analyses performed on the topic. We published the last one from our group in 2023, putting together over 40 trials and using different analytic approaches, using subgroup analysis and other sensitivity analysis that we can explore further. But when we have all the studies combined, we have seen that we have a moderate to large effect on depressive symptoms in people with depression or depressive symptoms. So yes, and when we say that's a moderate effect, is considered a very good statement because most of the interventions for depression, they have small to moderate effect sizes, and we have to take some care when comparing different interventions. But the message that I want to pass through is that we have consistent evidence showing that exercise works and can reduce at least moderately the symptoms of someone with depression.
And I think you alluded to something there as well, right, in that this is effective for people with major depressive disorder and for people with subclinical symptoms of depression who might have symptoms but not necessarily meet criterion for a clinical cutoff. So, across the spectrum, if you like, of depressive symptomatology, exercise seems to have considerable effects.
Indeed. One of the sensitivity analyses that I just commented that we performed in the meta-analysis, it was that one, trying to differentiate the effects of exercise in those that just have depressive symptoms, but not necessarily a formal diagnosis of depression, and people with a formal diagnosis of depression meeting all the DSM criteria or ICD criteria for depression. And yes, we can say that exercise works for both of them, and that should be encouraged as a potential intervention for everybody. That, let's say, there is no restriction whether people with higher severities of symptoms can do or shouldn't do exercise. So exercise can benefit anyone that can exercise. That's one thing that's important. A question that is quite common is, do people with severe depression or moderate depression exercise? And do they benefit from exercise? And the answer for both questions is yes. Yes, they can benefit from exercise. As I said, my first trial was with severely depressed inpatients in a psychiatric ward, and we did find some significant benefits. And yes, people with even with severe depression, they can exercise. Obviously, that are much more challenging to encourage people with depression to exercise. We know how hard it is to anybody change their behavior. Obviously, when someone is depressed, there are additional barriers towards the adoption of an active lifestyle. But yes, it is possible to make them exercise. And one thing that's important, I don't know if you are about to make these questions and I am just going through
That's fine.
before you ask me. Yeah. But one thing that people have in mind is how hard should be the exercise, or how intense should be the exercise for someone to benefit. We have seen in meta-analysis benefits from different intensities, like even moderate or intense or even light exercise can be beneficial. But the best exercise is the one that is actually done. So many people believe that just the intense exercise will bring benefits, and some people with depression won't exercise hard. And obviously, you shouldn't encourage someone with anybody that is not doing exercise. You shouldn't encourage them to start exercising in a very intensely. So it should be progressive. But yes, you can have different benefits from different intensities and start slow and progressing to higher intensity and higher frequency and etc.
Yeah. So the meta-analysis that I think you're referring to with the lead author, Heissel, I think is how you say it, 2023, which you were a part of, right? It seems like you guys did find that moderate and vigorous intensities tend to have large effect sizes. And I think seems to be quite a consistent finding. One of the recent network meta-analyses, Notel et al. 2024, looked at 200 plus studies as well. They saw, I think, a dose response relationship for intensity. But the point you're saying then, right, is about adherence. Okay, what's the point in having a really intense exercise regime if the person can't actually comply or adhere with that? Then you're not going to get any benefit from it.
Mm-hmm. Yeah, one thing is that we should always consider that is the effective response to exercise. What it means is that exercising in higher intensity may provoke negative feelings for those that are not used to exercise in that intensity. What I mean is that exercise may not be equally pleasant for for people that are training, that are used to training, and for the ones that are just starting to train. So if you propose that someone that's not used to exercise, to start exercising vigorously, probably the effective response to that exercise would be much more negative than positive. And by negative, I mean people will feel not so pleased, will probably is less likely to enjoy the exercise, would be a bit more pain and more negative feelings in general, which is quite different from someone that's used to exercise. People that are used to exercise, they are more likely to experience positive feelings, to have positive effect for that exercise session. So when you say, this is why we should take some care when we say that, okay, just moderate or intense exercise works for depression, we may this encourage people to start doing light exercise, but light exercise for the ones that are untrained may be the best option to start to actually change the behavior that people want, to make them feel comfortable exercising, to make them create a positive affective experience when doing exercise. So this is something that we always have to have in mind when we are trying to prescribe exercise or to recommend exercise for someone with depression.
Yeah. So on that note then, Felipe, can, say, a low intensity walk around the block, for example, can that have depressive or antidepressant effects and reduce depressive symptoms?
When we look at the meta-analysis, the answer is probably the effect will be small if the person has any effect. But the point is, it's more important than to have some benefits at the beginning in a short time is to create and change the habit and try to make the person have a positive experience from that session. For example, we have some evidence showing that high intensity interval training is very effective in reducing depressive symptoms.
Okay.
But have you ever tried to do high intensity interval training? So most people, some people really enjoy that, but most people say, well, that's too much to me. So I would rather prefer doing some more moderate exercise. So that's the point. If you think that intensity is everything when you want to try to make people change their behavior and become active, you should also consider other aspects like how people feel during exercise. So this is why I, before saying what's the best intensity, I prefer to say this is the best exercise for that person at that moment. And the best exercise for that person at that moment is the exercise that people can tell positive things when concluding the exercise. Is the best exercise is the one that in the end someone say, okay, that was fun, that was nice, I enjoyed, or at least that was pleasant. I will be here tomorrow for doing something more. Otherwise, you can just make people exercise vigorously, and at the end they say, no, I'm exhausted, this was really too much, I'm not here tomorrow because I'll have to restore my energy and my muscles, I'm feeling pain. So that's the thing that we should avoid in the end.
Yeah. And so I had one of your co-authors, Dr. Oscar Lederman, on, and he mentioned something, a nice little catchphrase of start low and go slow. So particularly for people who are sedentary, like you said, meeting them where they're at in terms of intensities, and just slowly building up from there with a longer term approach in view. And as well, I've seen some work really supporting, I suppose, what you're saying about affect in exercise is predictive 6 and 12 months later of someone actually doing that exercise. I think up to 30 or 40 minutes more per week for one increase on the scale of affect, the feeling scale. This is work by, I think, David Williams, 2008. So essentially saying that, and this makes sense, if you're doing something that feels good in the moment, you're more likely to continue doing it and making that a longer term habit, which is exactly what you're saying.
Exactly. That's the point. So it's the same with other lifestyle behaviors. Like if someone prescribe you a diet that you say, no, I don't like this food, I am not eating this stuff, I just don't feel pleasure here. There are much more chances for someone just quit this new diet and just get back to the usual one. And it's the same with exercise. If you prescribe exercise that's making people actually feel bad when doing exercise, there are much less chances for for the people just engage in exercise and keep exercising. This is like the basics. And we have to acknowledge that people have feelings, and these feelings should be considered in every lifestyle behavior, including exercise.
Yeah. So then this notion about individualizing it to make it sustainable, Felipe, I imagine that you can transfer this to type of exercise. And indeed, it seems that lot of the meta-analyses have found moderate to large effect sizes for aerobic, resistance exercise, yoga. So can you speak to anything there about the type or modality of exercise and the antidepressant effect?
Yeah, sure. So in this meta-analysis that we published last year, we also explored the different types of exercise. And we have seen that either aerobic and strength exercise or the combination of them, all of them are effective to reduce depressive symptoms. This is a good message for us because if both exercises can have a positive effect, that means that you can decide which one's the best for you. So if you ask for some colleagues or some students or to anybody, what's the best, what's the exercise that you prefer doing, aerobic or strength training? You probably will have some people saying, I prefer aerobics. I love running, I love cycling, I love swimming. And not some other people say, I love going to the gym. For example, I love going to the gym, but I can run, but it's not like, oh, I love to run, but I really love going to the gym. And some people are just the opposite. And this is something that can also modify the affective response. So if we're doing a sport that you just don't like, probably there are less chances for this behavior to be consistent and to be kept in a period of time. So if you tell me, oh, you have to run to achieve some benefits, okay, I will run, but I would be rather preferring doing some strength training. So, but some people will say, oh, you have to run, and some people say, no, I hate running. This is something that I really dislike. If I have to run to have some benefits, no, I'm not doing that. I'm just going to the pills, and that's it. Yeah. So if you have benefits in different modalities, you can see whether or which one is best for each person.
Yeah. I must say, it was a relief to see that you can see the antidepressant effects for different types of exercise, because I, like you, and much more of, get in the gym and do weights. If the results were such that it was only aerobic exercise and running, I would probably not do it because I hate running. So, and I think that's probably echoed by a lot of people, right? People have different preferences, like you said, whether it's doing yoga, whether it's running, walking, lifting weights. So certainly relieving to know that you can choose your own method and path to unlock the antidepressant effect of exercise, if you like. So one of the interpretations I have from the evidence is that there are some null findings for exercise on depressive symptoms. So, for example, a Cooney et al. 2013 Cochrane review, I think, found that when you only have trials with a lower risk of bias, there's a really small or next to no effect for the exercise on depression. Can you speak to some of either the limitations of the evidence of exercise for depression, or just on some of those perhaps quote unquote weaker findings for the antidepressant effect of exercise?
Yeah, sure. Yeah, that's interesting. The Cooney meta-analysis was heavily criticized by many people, including Pantelimon Ekipakis, that's an author from our field. He wrote a whole piece of paper just highlighting the issues in that meta-analysis. But that's not the case. Jesper Krog in 2018, maybe, or 19, sorry, just missed the year in my mind. But he wrote another meta-analysis that was published in the British Medical Journal of Psychiatry. And he also did not find any significant effects of exercise when you limit the subset of high-quality articles. In our meta-analysis published in 2023, we did find significant effects. It was a larger meta-analysis updating the literature and considering the most recent evidence available. And we still did find good evidence showing that exercise works. But there are some limitations. In fact, most of the literature is from studies that are considered of having high risk of bias. Because doing trials in the exercise field is not that easy. For example, you can't blind the participant. It's impossible to make the participant unaware that they are exercising. So it's just not possible. And it's the same for the one that is prescribing the intervention. The people, the professional that is prescribing or following or supervising the exercise session, they know that the participant is exercising. And this in trials can elevate the risk of bias. This is one thing that's important, and there's basically nothing we can do about that. It's, on my view, it's impossible to make someone exercise without knowing that it's exercising. And in this regard, this is somehow similar to psychotherapies. It's the same issue. But most people don't say that psychotherapy doesn't work for depression, even having the same issue in the field, because it's impossible to make someone do psychotherapy without knowing that it's actually talking to someone. Obviously, it's possible to blind the technique, but the participant is still receiving some kind of intervention and some kind of support. So that's the point. But it's also important to notice that exercise works for some people and not for everybody, as it is for any other intervention for depression. If we look to the response rates in the trials that we have, the response rates are about 40 to 50%. That means that approximately half of the participants that start exercising will perceive some clinical benefits from the exercise. And you say, okay, that's not that good because, well, 50% is not optimal. And yes, I agree with you. I would love to say that the response rate of exercise is much higher than that. But if you look to the response rates of other interventions, including pharmacological antidepressants, it's quite similar. Once again, it's quite difficult to compare, and it's inappropriate to compare directly these interventions because they are completely different interventions with different aspects. But if you look to the response rates, they are. What I want to say is that we don't have any perfect intervention for depression. All interventions that we have at this moment, they can help. They are useful for some people. So, like the response rates for pharmacological antidepressants are about 20 to 30% higher than the placebo response. So that's a good, not a good thing. Obviously, we wanted to have much better interventions. But the thing is that we should be aware that exercise may help some people and probably won't help some other people. And the same with psychotherapies or pharmacological therapies. And from my view, what we should use and how we should use this information is we have to consider patients' preferences and try to tailor interventions, knowing that some interventions will work very well for some people and some others will just won't. So that's, for me, is a very, very clear message. And we need to make use of all interventions that we have in order to try to achieve better results in the field. So if you stop and think what have been happening with depression prevalences over time, they are pretty much stable, excluding in young people. That's like rising, and obviously the pandemic changed the scenario. But we have been trying to produce new antidepressants and new interventions, but still the prevalence of depression is stable over time. So that means that all interventions that we have have their role. Depressant rates are not increasing, but there is no perfect intervention. So we still have to consider multiple interventions for a single or for different people.
Hello everyone, a quick break from today's episode. At the Mental Wellbeing College, we are committed to the goal of communicating evidence-based wellbeing strategies out to the broader community. The goal of this podcast is to bridge a gap between self-help material and peer-reviewed research by providing evidence-based discussion that respects the nuances of psychology but is digestible for all audiences. Ultimately, I hope that you as a listener feel empowered after each episode so that you can take away and implement strategies to improve your own mental well-being. If you have gained value from this episode of the Mental Wellbeing College, I would be so grateful if you were to hit subscribe or follow, or to share this episode with someone that you love. This is how we continue to grow the show, get the message out, and to impact people in need by providing such information and strategies. Thanks so much for tuning in. It means a lot to us here at the Mental Wellbeing College. And now back to today's episode.
Yeah. I certainly love what you're saying there about patient preferences, and this brings to mind something like the shared decision-making model, where you're able to offer different options to different patients or clients, give them informed choice as to the evidence behind each one, what taking antidepressants might look like for them, what engaging in psychotherapy might look like for them, what engaging in exercise might look like for them in terms of helping with their depression, and then allowing them to be the experts in their own life to an extent and make that choice. And certainly having exercise as an option would increase that variety of options that they have. And also this speaks to, I suppose, the use of exercise perhaps as an adjunct in conjunction with psychotherapy or pharmacology, which a lot of the national guidelines, like even here in Australia, the Royal Australian College of General Practitioners are now advocating for, which is as a first-line treatment for mood disorders, therapy plus exercise, or medication plus exercise as an adjunct.
Most of the available literature investigate effects of exercise in combination to other treatments. And there's no reason for not using all weapons that you have in this arsenal. There's no reason why not combining exercise with medications or with psychotherapy. They are not exclusive. So as more options we have, as higher as the chance to win this victory against depression. So considering patients' preferences is crucial on our view, because all interventions have downsides. So pharmacological antidepressants, they have side effects. Some people can't take them for a long time because of these side effects. And also exercise has downsides. Some people may lack motivation to exercise for a period. And it's quite similar to psychotherapy. Some patients may lack motivation to go to the psychologist or to psychiatry to do an intervention. So the good thing is that we can use them all together and combine it, and there's no reason to exclude them. There's no interaction that would make necessary to just use one and not the other.
Yeah.
So.
Yeah, one thing I'm very interested in as well is how this gets translated to primary care, to the psychologists, the general practitioners, to physicians who are actually out there treating people with mental health conditions or mental illnesses. And I know, my background and training is as a psychologist. There's not much at all formal training we get on exercise as a tool for mental health. It's all therapy and pharmacology. So, hence something like a podcast like this, which goes out to a lot of students. But I certainly feel like there's room for improvement there, such that you get more practitioners having this in their toolkit to use in therapy. But if they're not trained on it, it's not going to happen.
Yeah, and it's the same in the whole world. It's like every professional is just closed in their own niches, just exercise professional, just study about exercise. Psychology is just about psychotherapy and some part of medication and so on. There is no conversation between these different fields. And one thing that's quite often asked to me is that, oh, what should I do to make my patients to exercise? Because I have been asking them to exercise and saying that's good, and it's not working. And obviously, I'm not impressed that this is not working. It's like if you try to go to someone that smokes and say, "Oh, stop smoking. That's not good for you." What are the real chances for having these people stop smoking? And it's like the same with exercise. So the best way, in my view, to actually, in fact, to support patients to start exercising and some stuff that we have seen in the literature. The first one is that if the psychiatrist or the psychologist is active, higher the chances of the patients to start exercising because it can create a stronger connection. The psychologist is given the example, and this is helpful. Oscar, as I said, has a study on that showing that psychiatrists that are more active, they are more likely to promote and be successful in promoting exercise for their patients. And also, a part of that, something that we should take in consideration is that how much time takes for a psychologist or for someone actually encourage someone to change and make a viable way to people change their behavior. So the first thing is that just saying that exercise is good for you, go exercise, or even prescribing, do it for 3, 4, 5 per week, 20 minutes or so. This is just not effective at all. We have seen in the literature that the best way of actually promoting exercise is trying to build and to explore according to patients' preferences what would be the most suitable and preferable exercise for that patient. Just telling them to exercise is not sufficient at all. Everybody knows that exercise can help your physical and mental health. There's no new in that. What should change, in my view, is that every ML professional working and attending to someone with depression or any other mental health problem, this profession should try to explore how the best way and to make that people actually exercise given their context. Like exploring, for example, what would be the best exercise for that patient, exploring how the patient feel when doing or after doing exercise, exploring what the best time for that patient, exploring if he or she enjoys doing with someone else, listening to music or just quietly. So actually trying to make people understand what would be the best exercise for that specific person. That's the best way, and this takes time. Like it's not just saying exercise is good. It's quite quick. It's like okay, just do it, but it's not effective. So the overall recommendation from us researchers in the field is that the health professional that's trying to encourage patients actually try to explore how to make the patient exercise in their real life, given their context and given their preferences. Not just saying exercise is good and go for it. That doesn't
Yeah.
work.
This is an extremely important point, the adherence problem. I've seen it termed as the no-do gap, that people know exercise is good for them, yet doing it is a different problem, and there's a gap between the knowledge and the doing. And Steve Petruzzello, I think he was the PhD supervisor for Paddy Ekakakis. I've seen him term this as exercise is a best buy but a tough sell. So great benefits and everyone knows of it, and there's been this proliferation, explosion of knowledge on the great outcomes that exercise has both physically and mentally, yet rates of physical activity on a national and global scale are still very poor in terms of people meeting the national guidelines, right? So this is the big problem that is yet to be unlocked, is how to bridge that no-do gap.
Yes, exactly. And this is something that Ekekakis is trying to explore. And the answer that he gives is the one that I adopted, is that people know that's good, but they don't feel that is nice doing. So the effective response for most people, or the effective memory of exercise for most people, is not a positive memory. If you ask many people or some people if they like or if they enjoy exercising, some people will say, no, I hate it. I rather prefer staying in my sofa just watching TV. And it can be quite true. So I can make you feel very badly exercising. I know how to do that. But we have not been trained to make people feel good when exercising. And this is a problem of the field. We have been so much interested in intensity and the physiological effects of different intensities and the physiological effects of different volumes, but we haven't explored how these variables can affect the effect of the person, can affect the emotional, and how we should work with these variables to make someone feel good when exercising. So uh, people that have positive affective memories from exercise, they are more likely to keep exercising and to enjoy doing exercise. And this is something that we should explore. And this is why I say maybe light exercise could be a good option for someone that have not exercised previously, because you have higher chances of that people end or conclude the session saying, okay, that was nice. I like it doing. I felt good, and I'm here tomorrow. So this is like probably the missing part. People can make people feel very bad, and we should take this into consideration when prescribing exercise. And if you use the same exercise session or model or prescription for a group of people, some people will say, okay, that was very nice, and some people will say, no, that was awful. That was terrible. This is the challenge we have here, is how to tailor the intervention based on the effective response that people may have from exercise. And this requires a fine-grained approach to try to explore session by session, or at least to try to make the patient or the people understand how they feel doing exercise, and what did work, what didn't work, what made him or her feel bad, and what made him or her feel good. And exploring these alternatives is like probably the best one. If we can try to make people exercise feeling good most of the time, well, this is how we can probably change this scenario and make people benefit more from exercise as well.
Yeah. So to counter that, anecdotally, speaking to a lot of GPs or physicians here in Australia, a lot of them, in terms of prescribing exercise for mental health, feel that they need concrete guidelines. They need to be told that then X, Y, and Z exercise for depression, X, Y, and Z exercise for 10 minutes, whatever, 20 minutes of this type, this intensity. They want those kind of black and white guidelines. Now, it seems like from our conversation, from the research, that's kind of the opposite approach that you're advocating for, and that rather than looking for the magic dose or the magic pill equivalent of exercise, the best way is to adopt more of the health behavior change approaches and individualizing it for a person. So something like self-determination theory, which I know you're familiar with. And that's the way that research should go, is looking at individualizing health behavior change rather than what's the most effective dose, Is that a fair summary of how things sit from your point of view?
Yes, that's a very fair summary, and that's exactly the message. We know that from psychiatrists or from a health professional that has limited time, that has lots of pressure of other things. I know that they just want a receipt that's saying, okay, just do that, and this is probably what would work for you. But we have seen in the field that this is not how it works. We have seen that we have to consider individual preferences and individual values and individual affective responses. And this is quite challenging. We have seen in the field that we have to try to standardize an approach, in my view, to assist health professionals to try to change behavior, and providing maybe steps on how to explore these points that we just discussed. But this is not just an easy prescription. It's not like just going in and doing that, because that doesn't work at all. If you just tell someone that he or she should stop smoking and just prescribe, maybe you should stop smoking every day and start smoking 5 days per week, and then 4, and then 3, and then 1 per week, and then you can just quit. And that doesn't work. This is not what happens in real life. So why should we believe that that approach would work for making someone exercise? It doesn't work at all. It doesn't work for diet. It doesn't work for any other behavioral change intervention. So it probably won't work for exercise at all. So we should consider using different approaches and more complex approaches, indeed. Approach that requires more time to explore and to discuss with the patients. But it doesn't matter if you are just spending 5 minutes and that's not working at all. It is not relevant. So it's much better to spend like 20, 40 minutes per month to discuss something that can have a real impact on the patient's life.
Yeah, I could talk to you for hours on this, Felipe. I don't know if I told you this, but I've just started my PhD here in Australia, and I'm looking quite closely at adherence to lifestyle behaviors in university students. And one of the studies I'm looking to run is like a mixed method study looking at health practitioners and their use of exercise prescription with young people. What are their barriers? And you brought up one, which is time. As a GP here in Australia, our public health system is under such strain, and you're right. At least here, they just don't have time and are under such huge workload pressures to have these conversations. But in terms of where we're at now and health behavior change theories, are there particular models or frameworks that health practitioners can follow that are effective in increasing the adherence of health behavior in general, if not exercise?
So Dave Van Kamper, a colleague of us from Belgium, has done lots of work exploring how to use the self-determination theory to facilitate and integrate and to do these behavioral changes. So like creating a sense of belongingness, or assisting the patient to create this sense of belongingness, to try to make an exercise session that the patient can feel that he's competent in doing that, like trying to propose an exercise that's actually doable and feasible for the patient. It's something that can be very, very positive in terms of adherence. And that are the things that can really help patients. If you consider the self-determination theory and try to change change the behavior using the autonomous motivation, trying to explore what is important, what's relevant for that patient in that context, in that moment, it's like something that we can use as a background theory. Obviously, this is not that easy because when I say, okay, just use that theory is not that helpful for physicians and for GPs. But basically, based on this theory, you can try to explore with the patient what are the values, of what are the feelings, what are the views of the patients regarding that exercise, and that can help somehow.
Yeah. I'll certainly put a link in the show notes because I have seen some of that work from David Van Camfort, who exercises more in depression participants, one of his studies, which is really interesting reading for those who have the time to check that out. Yeah. So we've covered a lot, Felipe. I think the final thing I'd love to cover with you is some of the hypothesized mechanisms behind why exercise works for depression. And I say the word hypothesized, intentionally, given there's no real one answer as far as evidence goes. And I mean, my assumption is that it's probably going to be a suite of different mechanisms that work for different people. There's different exercises as well that work. It's not just aerobic or resistance. So it makes sense that there'd be different ways or pathways to working. But can you comment on what we do know about some of the mechanisms, or what some of the plausible mechanisms indeed are?
Yeah, we have some hypotheses. We have no certainties here, as we don't know what are the neurobiological mechanisms of depression. So that's quite simple, for example. It's not quite simple, it's quite complicated. We don't have a clear answer. We have some hypotheses here. One hypothesis that we have is that exercise can enhance the secretion and the production of BDNF, for example. BDNF is the brain-derived neurotrophic factor. This biomarker is associated with neuronal growth and development. So it seems that when we exercise, we release this biomarker, and this biomarker can stimulate the neuronal birth and development. And we have some evidence showing that people with depression have lower levels of BDNF. So it's possible that exercise can enhance the level of this biomarker, and this can somehow explain the antidepressant effects of exercise. But we don't have strong and clear evidence on that, as we don't have clear and strong evidence showing that this is what causes depression. So it's one hypothesis that we work on. Another one is that we have seen that people with depression and with some other psychiatric disorders like bipolar disorder and schizophrenia, they have an impaired inflammatory system. We have seen that people with depression, for example, they have higher levels of pro-inflammatory cytokines and lower levels of anti-inflammatory cytokines. Exercise can acutely increase pro-inflammatory cytokines, but in a long term, exercise can reduce pro-inflammatory cytokines and increase levels of anti-inflammatory cytokines and regulate this inflammation or inflammatory system. This is another hypothesis that is being discussed on the field. We have one piece of work showing that exercise can increase the hippocampus of people, of everybody, including people with depression. This was a piece of work led by Joseph Firth from Manchester. And we have seen that exercise can actually increase the hippocampus volume. And we have some evidence showing that the hippocampus is one of the brain structures that is affected by depression. So exercise can increase the hippocampus volume. And we have seen that depression is somehow related to a reduce in this volume. Maybe there is a connection in this field. But here, once again, we don't have direct evidence connecting or associating the antidepressant effects of exercise to a change in hippocampal volume. These are some of the hypotheses that are more consistently used in the field. We have some other hypotheses that still require some exploration in humans. That is, until at this moment, is just used and explored in animal models. In animal models, we have many other biomarkers being studied, but with no evidence in people with depression, in humans with depression. These are the main biological or neurobiological mechanisms. We also have some other psychological mechanisms, like exercise can, or physical activity can connect people, can make people, for example, when you have a professional that's supervising you, or when you are exercising with some other people, you can have some support from the people while doing exercise. Obviously, it's not an exercise. It is not exercise itself that is acting through these mechanisms. Is this because you have social support from someone else? But it can be associated to exercise as well. We have one mechanism that was very much used and referenced in the 1980, that is the distraction mechanism. Some authors say that, okay, when you are doing exercise, you are just thinking something else and not ruminating in your negative thoughts. And if you are not ruminating and you are just thinking someone else, this may represent a relief. And before the pandemic, I was like, this is probably not that much important. But in the pandemic, we realized that just not thinking about the pandemic situation and how things were bad at that moment can somehow help us to alleviate at some degree, the stress levels and even depressive symptoms. And this is one of the potential psychological hypotheses. And we also have the self-efficacy hypothesis that most people with depression, they say that they are not competent in doing anything. They just, okay, you can do that. And someone with depression say, no, I can't do that. I'm not able, I will fail. I'm not good. I don't have the skills. I can't do that. And actually, when people feel that they can actually do and be competent in doing something, this may represent something for that patient. And from that, you can use this kind of positive experience with exercise to say that, okay, you can exercise, you are good in doing that, and maybe you are doing some other things. Maybe it's just how you see and how you perceive yourself. You perceive yourself not being good in doing something, but you actually are. This is quite clear. We have some evidence showing that when someone is exercising and feel competent in doing that and achieves the goals of that session, there are higher chances of someone feel good and to improve from their symptoms, for example. So this is also how this mechanism connects with the self-determination theory. You make people feel competent, feel good, and feel that they have the skills to do things and even to exercise. So when someone feel that's good doing something, maybe this feeling can be transported or used in different areas of patients' lives.
Yeah, almost a sense of proof of concept if you can achieve something in something that's very hard and difficult, because, depending on your severity, but depression can make it difficult to get out of bed in the morning, leave the house. So if you can go for a walk, engage in a gym session, then you can apply that to other areas of your life. Like you said, it's almost a form of behavioral activation as well, in the sense that, getting a sense of some of those feel-good chemicals and increased mood in one area can translate to other areas of life. So yeah. Interesting as well, commenting on the distraction side of things. I talked to Pat O'Connor from University of Georgia, who I think was one of the big proponents of the timeout hypothesis. And again, this is just anecdotal, but yeah, just reflecting on me. I don't know how you go about your, weights and gym training, but for me, it's very much like I just put my earphones in. I don't want to talk to anyone, and it's just like 60 minutes of just alone time where I'm just kind of, with my own thoughts. And it certainly rings true for me. But then also you look at, right, like different forms of exercise, how yoga is so different to weights, is so different to running. Again, coming back to that earlier point, it makes sense that there are different mechanisms for different types of exercise, and that potentially that might even play out in the neurobiological sense when you've got something like yoga with a meditation and mindfulness component, very different to running with a friend, or squatting 100 kilos or whatever it is that you're doing.
Yeah, for sure. And unfortunately, we are still a way, in my view, to discover what are the neurobiological stuff that is behind this effect, because we are far away from knowing what's the neurobiological changes that we have in depression. So from that perspective, it's far away, but the psychological mechanisms, this is how we call in the field, all this latest one that we discussed, they are very applicable, and probably they make much more sense than the neurobiological ones at this point.
Yeah, I know. When I read, is it your 2016 or 2018 systematic review of neurobiological mechanisms of depression, I was disappointed because I was like, okay, there's going to be one answer here. It's going to be great, a clear pathway. But the message I took away was that there's no real clear pathway.
Yeah, and the bad news is that we are just working in updating that evidence, and the answer is still the same.
Okay.
There is no clear biomarker or clear evidence on any biomarker that can explain this effect. So not at all.
Okay, yeah. That's okay. Watch this space. Maybe one day. But yeah, is there anything finally, Felipe, that you want to impart upon listeners or share with students tuning in?
No, I just wanted to invite the first semester and first year students to participate in the Unilife study. So this is that would be very important for us. The Unilife study at the Australian National University is being led by Lo Farrer. Sorry about my pronunciation. My Brazilian Portuguese accent is quite strong. So Lo Farrer is leading the study in there, and it would be great to have you participating of this study. And yeah, that's it. And also I wanted to thank you very much indeed for having me and for all the students that are listening to this podcast. And once again, sorry about my pronunciation and my English mistakes. Eventually I do some. But yeah, thank you very much for your attention.
Thanks so much for tuning in to today's episode of the Mental Wellbeing College. If you've made it this far, it means you've gleaned a ton of value from today's episode, or you've fallen asleep. I sincerely hope that it's the former, and if it is, I would be so grateful if you were to hit subscribe, follow, or to share this podcast with someone you care about. Our mission here at the Mental Wellbeing College is to provide a free and accessible resource for people to take action and implement to improve their own mental wellbeing. And you subscribing, following, and or sharing helps us to achieve that mission and to impact people in need. Thanks so much for tuning in. It means a lot. We'll see you next week on the Mental Wellbeing College.